Sir,
Or
good morning, sir. Are we going to open the camera?
it's up to you.
Okay, okay. Let's start. Good morning, everyone. We are the first reporter for today, the group of FPJ, with our case study about skin soft tissue infection entitled the Staphylococcus martin aureus. So let's start. Case 1. Mr. Gary Sponge, a 35-year-old male, had a motor vehicle accident 2 days ago. He was awake at 12 a.m. with redness and swollen calf. He decided to put ice pack on the area and sleep again. At 8 a.m., he noticed a small amount of pus from his swollen calf. Over the next 8 hours, the patient developed cellulitis on the lateral aspect of the calf, approximately 4 by 8 centimeters. At that time, a small amount of pus was again expressed from the area. The next morning, the area of cellulitis extended from just below the knee to just above the ankle. The patient visited SWUMC Emergency Department. His vital signs at that visit include pulse rate 85 beats per minute, respiration rate 15 beats per minute, blood pressure 110 by 80, and temperature 36.9 degrees Celsius. Physical exam was significant for an area of cellulitis as described that was red and warm to the touch, but with no area of obvious fluctuance. No lymphadenopathy was observed. The central area of the cellulitis was punctured 3 times with a 20 gauge needle, but no pus was drained. The patient was referred to the surgery department and was given 2 grams of ceftriaxone intramuscularly and oral cephalexin. The patient returned to the surgical clinic 48 hours later with an obvious area of fluctuance in the center of the area of cellulitis. Over the preceding 48 hours, the patient reported low-grade fever and hypotension. Approximately 1 ml of pus was aspirated and was sent to gram stain and culture. The laboratory susceptibility results of the organism are seen in Figure 1.3. Figure 1.1, direct gram stain. It shows a gram-positive cocci in clusters and white blood cells. Figure 1.2, on blood agar plate, yellowish colonies and surrounded by a wide zone of beta hemolysis. Figure 1.3 shows the different susceptibility results of the organism. The patient's general information. This is a case of GS, a 35-year-old male that was admitted 4 days after his motor vehicle accident. The patient's chief complaint is the area of cellulitis extended from just below the knee to just above the ankle. His other symptoms include the redness and swollen calf, formation of pus, visible cellulitis on the lateral aspect of the calf of approximately 4 by 8 centimeters. The history of present illness. 4 days prior to admission, the patient had a motor vehicle accident. 2 days prior to admission, the patient experienced redness and swollen cough and pus formation. No fever and hypotension were observed. Prior to admission, the area of cellulitis was red and warm. No fluctuance, lymphadenopathy, and fever was observed. After the drugs are given, the patient experienced low-grade fever and hypotension. 2 days after drugs are given, there was a fluctuance in cellulitis. The patient's past medical history was undisclosed. The patient's family history was undisclosed as well.
For the social and drug history, the patient took 2 grams of ceftriaxone injected intramuscularly and oral cephalexin. This is after 48 hours since his first visit. For the comorbidities, it was undisclosed. For the physical examinations, for his first visit, his vital signs are as follows. For his temperature is 36.9 degrees Celsius. His blood pressure is 110 over 80. His pulse rate is 85 beats per minute, and his respiration rate is 15 beats per minute. While his physical examination for his first visit is cellulitis with red and warm to the touch and with no obvious area of fluctuance. There is also no lymphadenopathy and no pus was drained. For his second visit, his vital signs were as follow. His temperature is 37.8 degrees Celsius, which is low grade fever, and his blood pressure is 80 over 40. So it shows that his temperature and blood pressure has decreased. While the physical examination, there is cellulitis and there is an obvious area of fluctuance at the center of the area. And also there was pus. For the pertinent laboratories, as you can see, there is color purple with clusters, which is gram-positive cocci in clusters, and also white blood cells. For the blood agar plate, there are yellowish colonies and surrounded by a wide zone of beta hemolysis. For the susceptibility test, there are 5 drugs that are susceptible to the organism. Drug 1, trimethoprim, sulfamethoxazole. Drug 3, which is doxycycline. Drug 5, the vancomycin with an MIC of 2 macrograms per ml by e-test. And drug 6, gentamicin. Drug 7, clindamycin. Also, there are 3 drugs that are resistant to the organism, which is drug 2, cefoxitin, drug 4, which is penicillin G, and drug 8, which is erythromycin. By the way, what is e-test? E-test is a method for minimum inhibitory concentration or MIC determinations in laboratories. The MIC is the lowest concentration of an antimicrobial agent that prevents visible growth of a microorganism.
So for differential diagnosis, the disease being presented below are all bacterial infection associated by Staphylococcus aureus bacteria. So for skin infection symptoms, to consider are cellulitis, toxic shock syndrome, bacterial skin infection, and furuncle and carbuncle. So all the diseases presented meet all the symptoms which has the redness, swelling, fever, and as well as low blood pressure. For the physical examination presented in the case, it was shown that cellulitis with visible fluctuance, there is no lymphadenopathy and no pus drained at first. So the patient was suggested to undergo surgery, and after 2 days, cellulitis with visible fluctuance, and the patient developed low-grade fever and hypotension. So our group came up with the diagnosis that the patient is suffering from carbuncle. Why? Because it has met the symptoms that red swelling, fever, and also low blood pressure. And also it met the it met the Staphylococcus aureus mode of transmission, which is acquired if there is injury such as cut, fracture, burn, or scrape. As we have stated, that our patient had undergone a vehicle accident.
Organism concept map. Gram-positive cocci cluster causes skin infection is staphylococcal species. There are different types of staphylococcal species. These are S. aureus, S. epidermidis, S. saprophyticus, S. lugdunensis. To differentiate the staphylococcal species, sheep, blood agar, or SBA were used. In SBA culture, S. aureus yellow colonies beta hemolytic, S. epidermidis white colonies non-hemolytic, S. saprophyticus white colonies non-hemolytic, S. lugdunensis yellow colonies beta hemolytic. S. aureus and S. lugdunensis have the same result in BSA. However, to differentiate S. aureus and S. lugdunensis antibiotic were tested in which erythromycin antibiotic have different result in which S. aureus is resistant and S. lugdunensis is susceptible. Staphylococcus aureus taxonomy. Family name Staphylococcaceae, genus Staphylococcus, species Staphylococcus aureus. Its characteristics: gram-positive, its morphology spherical cocci arranged in single, pairs, or 3 to 4 chain or grape-like clusters, non-motile and non-spore forming. It grows readily on most bacteriologic media under aerobic or facultatively anaerobic conditions. Its optimum temperature for growth is 37 degrees Celsius. Its optimum pH for growth is at 7.4 to 7.5. Blood agar, beta hemolytic, and golden yellow colonies. Virulence factors are exfoliative toxins, hemolycins, protein A, and coagulase. Exfoliative toxins dissolve the mucopolysaccharide matrix of the epidermis, resulting in the generalized desquamation of staphylococcal scalded skin condition. Hemolycins establish a prepor after attaching to the cell surface and lyse RBC by rupturing their membrane, causing tissue injury and development of abscess. Protein A is a virulence factor that binds onto the Fc component of LGG to defend it from phagocytosis and enhance further pathogenicity. Protein A acts as a superantigen that binds to the Fc region of immunoglobulin, suppresses opsonization, and restricts the host immune response. Coagulase is an enzyme that is free in the bloodstream and bound to the organism by binding to the surface and assists in shielding from the immune system by reacting with blood factor in the blood plasma to commence clot formation and promote the deposition of fibrin around the organism to protect them from phagocytosis.
Staphylococcus infections are caused by 4 different types of Staphylococcus germs. These are the methicillin-resistant Staphylococcus aureus, the methicillin-susceptible Staphylococcus aureus, the vancomycin intermediate Staphylococcus aureus, and the vancomycin-resistant Staphylococcus aureus. Methicillin-resistant Staphylococcus aureus, or the MRSA, is an infection caused by a type of staph bacteria that become resistant to many of the antibiotics used to treat ordinary Staphylococcus infections. While the methicillin-susceptible Staphylococcus aureus, or the MSSA, is an infection usually treatable with antibiotics. It is a serious infection that has a high risk of complications and death. The, to measure the amount of resistance Staphylococcus has to vancomycin, laboratory test shows how much vancomycin it takes to prevent the growth of Staphylococcus. If there is only some resistance, it is considered as VISA, or the vancomycin intermediate Staphylococcus aureus. If there's a lot of resistance or have been susceptible to other antibiotics, it is called vancomycin resistant Staphylococcus aureus. Next. Culture and biochemical reactions. In culture, the colony that is being used in here is the blood agar plate. It is a yellowish colony and surrounded by a white zone of beta hemolysis. While in biochemical reactions, there are two types of tests, the coagulase and catalyst test. In coagulase test, there are two types, the slide coagulase and tube coagulase test. In slide coagulase test, if the result is negative, it indicates no clumps, while if it's positive, it shows the mersenne clumps. In tube coagulase test, if the result is positive, it indicates clotting, while if it's negative, it shows no clotting. In catalyst test, if the result is negative, it shows no bubbles. If it's positive, it indicates bubbles on the result. The diseases associated in Staphylococcus aureus, first is the skin and wound infection, the folliculitis, furoncles, carboncles, and bolus impetigo, and cellulitis. Folliculitis causes pimple-like sores under the hair follicles, while the furoncles causes boil, usually start as reddish or purplish tender bumps, and the carboncles is a cluster of boils that form a connected area of infection under the skin, while the bolus impetigo causes red, itchy sores that break open and leak a clear fluid or pus for a few days, while the cellulitis causes red, painful, and swollen tissue just under the skin. The toxin-mediated infection are the scalded skin syndrome, the toxic shock syndrome, and food poisoning. The scalded skin syndrome, or the SSS, affects the infants and young children. It causes the skin to peel off all over the body, leaving moist skin. While the toxic shock syndrome causes high temperature, flu-like symptoms such as headache, feeling cold, tired or exhausted, aching body or sore throat, and cough. While the food poisoning causes nausea, vomiting, and stomach cramps. Other infections associated in Staphylococcus aureus is the MRSA. It causes swelling, warmth, redness, and pain in infected skin. While the pneumonia, or disseminate bacteremia, it causes difficulty breathing, malaise, fever, or chills. While the osteomyelitis causes fever, swelling, warmth, and redness in the affected area.
Thank you, sir. That's all.
Okay. Any questions from the class? Do you have any questions you can ask to the reporters? Wala? Okay, I'll ask questions. You can open your camera now, reporters. Okay, question. Diba? Sa isang bahay lang kayo?
Yes, sir.
Okay. What made you decide that it's carbuncles to your final diagnosis?
Because it met all the symptoms, sir.
It meets all the symptoms. That's carbuncles results to hypotension.
Because of the cellulitis, sir.
Cellulitis. Okay. Um, have you read more about cellulitis? Cellulitis can also caused by Streptococcus pyogenes or your group A strep. How will you differentiate your group A Streptococcus cellulitis from your Staphylococcus aureus cellulitis?
Coagulase test.
Through the through the Kagalis test, sir.
Through coagulase test? Else. How about the appearance of the cellulitis?
To answer, kanang the appearance of the cellulitis is red and warm to the touch. Also, kanang nako siyang area nga red siya sa redness.
Swollen.
Swollen sa
Swollen, and you also mentioned about fluctuans. What is fluctuans?
Movable.
kanang irregular ang shape sa skin, sir.
Yeah, i-touch nimo, sir. Kaya movable siya.
And then, what else? Most of the Staphylococcus aureus cellulitis class is purulent. No, there is formation of pus, but for Streptococcus cellulitis, it's not purulent. So that is why for most of the S. aureus infection related to skin, when you touch it, it's movable. Possible there is abscess formation. Okay, because your organism may produce virulence factor which will cause dermotic lesions, okay, or dermonecrotic lesions. So can you give one primary virulence factor associated sa case?
Protein.
Which do you think among the virulence factor you mentioned
Ex-
or you've learned based on your readings is the primary virulence factor associated sa case?
Exfoliative toxin, sir.
Exfoliating toxin.
Exfoliative toxin E.
Okay, what else?
Coagulase.
Coagulase. Have you read about leukocidins? Have you read about leukocidins, toxins?
Yeah, Phantom.
Ano?
Panton Valentin.
Yeah, what's the action of Panton Valentin leukocidin? What's the action? Your Phantom Valentin leukocidin class is an important factor in necrotizing skin infection because your leukocidin primarily acts on the polymorphonuclear leukocytes. It's a toxin that will damage some of the subcutaneous tissues. That is why your patients experience democratic infections. And this is associated with the toxin release by the organism, and when the toxin release this organism, inflammatory mediators like your neutrophils will leads to degranulation. And once there is degranulation, obviously there will always be cytokines na responses na mahitabo. If there is na mga inana, di ba, cytokines na mga ma-release, if you go to your IS na discussion, if na yung mga ma-release na mga cytokines, then eventually it will lead to fever, and mo nang then kung mag-fever, also there will also be cytokines that will cause hypotensions. Okay, primary man na siya, reaction sa imong lawas. Okay? So, in this case class, this is not only limited to carpal infection. The case actually is a septic shock disease, primarily caused by a skin infection, caused in which the organism is MRSA. Okay? So, another question. What is MRSA?
Methicillin resistant.
How do you differentiate this from an ordinary Staphylococcus aureus?
Resistant.
It is resistant to penicillin, sir.
Huh? I can hear you.
It is resistant to penicillin, sir.
It is resistant to penicillin because of
Because
what?
Because
Because of which enzyme? We didn't read that. Because the organism produce
beta-lactamase, sir.
what does beta-lactamase do?
It
sir. Strengthen ang cell.
Huh?
it inactivates the lactam, sir.
The lactam? It inactivates the which structures?
It inactivates the beta-lactam antibiotics by hydrolyzing the peptide band, sir.
Okay, inactivates the beta-lactam ring present in your cell wall of the organism. Diba? The action of your penicillin, it binds to the beta-lactam, it inhibits the transpeptidase enzyme that will cause diba, the transpeptidase enzyme will help the organism to build the cell wall or will help the organism for cell wall synthesis. So if that organism is resistant class, mag-continue ra gyapon iyang cell wall formation. Okay? Ang buhaton ni organism iya to i-counteract ang action. Okay? You go back to your antibiotic sense result. There. Why do you think vancomycin is different from other antibiotics? If you notice, other antibiotics uses this diffusion, circular. Okay? Why is it that vancomycin uses ETES?
Para ma-determine niya ang lowest minimum concentration, sir, sa antibiotic.
What's the importance of the determination of the MIC for vancomycin?
Because it has methylase, sir.
Huh? It has what? Di ba? You mentioned a lot of types of staph aureus. You have the vancomycin intermediate and vancomycin resistant. Okay? CLSI guidelines class said that vancomycin should be identified using MIC because you cannot differentiate vancomycin sensitive from vancomycin intermediate. And there is already a rising cases of vancomycin intermediate. So that is why we won't use antibiotic disc for vancomycin determination. Okay? Ay nako, I expected you to read that. Wala man lang mo nahibong anong difference iya. Okay, another question. Why is it that clindamycin and erythromycin are placed together? If you notice, the distance between the clindamycin antibiotic, your drug 7 and drug 8 is very close to each other unlike with the rest of the antibiotics.
It is because it is because because the zone of inhibition of drug 6 affects the drug 7, 7 or 8. It is because the zone of inhibition of drug 7 affects the drug 8.
The zone of inhibition of drug 7 affects the drug 8. What is this test? If you still recall your antimicrobial susceptibility discussion, what is the test intended for these two antibiotics?
If a drug is susceptible, it is clindamycin, so is erythromycin.
Huh?
If a drug is susceptible to clindamycin, so is erythromycin.
Again? Huh? What test is this one? Your clindamycin, erythromycin. This is to detect what?
Can you repeat please the question, sir?
Di ba? In your previous discussion, erythromycin antibiotics and clindamycin antibiotics are placed together so that it will allow the detection of a resistant gene. And what test is this, Gani? Kana lang.
This diffusion, sir.
Ah.
This diffusion, sir.
Have you read about D-test? D-test, the inducible clindamycin testing in your previous discussion. The D-test class is is done to allow erythromycin-induced production of the methylase enzyme. The erythromycin ribosome methylase, this is a gene class that encodes inducible or constitutive resistance to clindamycin. And it's very important to note whether the clindamycin is sensitive or not, because there is a rising cases that for MRSA patients, most of the doctors before uses clindamycin as treatment, but a lot of cases will not confer good results to clindamycin. So meaning wala sila na treat for clindamycin. That is why it's very important if MRSA ang ma-isolate, clindamycin should be tested using D-test together with erythromycin so that we will know if the clindamycin is really susceptible or not. You read further about D-test na nasa previous na mga discussions. Amo ha. Okay, what gene is detected for MRSA? Unsa man na nga gene sa MRSA ang naa niya?
MEC-A gene.
Okay, the MEC-A gene. Okay, I'll ask questions from the group from other classmates. Celiote, Carla, is around? Celiote, Carla? Wala? Okay. Next, Erasmo. Erasmo Hara? Are you around? Erasmo?
Yes, sir.
Are you around, Erasmo?
Yes, sir.
Okay, can you hear me?
Yes, sir.
How will you differentiate Staph aureus from other staph species? Hara, how will you differentiate Staph aureus from other staphylococcal species?
Sir, coagulation test, sir.
What's the principle of coagulation test?
This test is used to differentiate Staph aureus from coagulase negative staphylococci.
Which test detects bound and which test detects free coagulase?
Slide, coagulase test, and the tube test, sir.
Unsa man si slide, free or bound?
Bound, sir, slide test. And for free, it's tube test.
Okay. Next, Singson is around.
Yes, sir.
Singson, Lay, ano siya? How do you pronounce your name?
Laser.
Lay. Okay. Can you give one virulence factor associated with staph and its action? Di ba nangukay pa?
Hemolysin, sir.
What does hemolysin do? What does hemolysin do?
Um, uh, Causes lysis of red blood cells by disrupting the cell membrane, sir.
Okay. If this, what is the result of hemolysin on blood agar plate?
Producing tissue damage and abscess formation, sir.
On blood agar plate?
Sorry, sir, wait. Sir.
What do you expect if the organism release hemolysin? You will see
Um, Yellow colonies, sir.
Yellow colonies. Okay, it's not the colonies class ha ang will form yellow, but it's the red blood cell. There will be hemolysis if ever the organisms release hemolysin. Okay. Another questions, by the way, to the reporter. How will you differentiate Staph aureus from Staph lugdunensis using antibiotic erythromycin?
Sa antibiotic erythromycin, sir.
Where did you get that?
Gusto ko question?
Using erythromycin antibiotic will not really give you a uh, definitive diagnosis or definitive differentiation between Staph lugdunensis and Staph aureus, because Staph lugdunensis may also appear as erythromycin resistant. So there is one test, no, that will differentiate what is this test. What is this test?
DNA. Ay, coagulase.
Which coagulase test?
Tube. Coagulase
Yeah,
test.
chog one, sir.
Okay. The tube coagulase will differentiate your Staph lugdunensis from your Staph aureus. Okay, that is why your tube coagulase is considered as confirmatory test, while your slide coagulase is considered as your screening test. Okay, let's review the case class. No, the case is it started with the cellulitis infection. No, develops into um, it develops into septic shock. Septic shock, why? Because if you notice, the patient experienced hypotension, no, and fever. If ordinary cellulitis lang na siya class, wala kayo na yung mga fever, wala kayo na yung mga hypotension. But see, in the case class, the patient already experienced hypotension. So therefore, um, the organisms is already present in the blood stream. Okay, so next slide, please. So the patient, the doctor requested for a gram stain of the wound as per it. So the gram stain revealed gram-positive cocci in clusters with white blood cells. So the white blood cells already indicates that there is active infection. Next. So on a culture media, primarily your blood agar plate, the organisms reveals yellowish colonies. Remember, your Staph aureus no release lipochrome or contains lipochrome. And this lipochrome, specifically staphyloxanthin, di ba, as your pigment shown by your Staphylococcus aureus. That is why your Staph aureus is named as aureus from the name aurum, di ba, AU, which means gold in periodic table. So the beta hemolysis there is the result of the hemolysin produced by your organism staph, primarily the alpha hemolysin. Next slide, please. So there, you have there the sensitivity result. This is a how you do sensitivity result. Again, the rest are disk diffusions. Also, the e-test is also diffusion method. But what is different lang, that this class primarily does not give you presumptive measurement of the MIC value, but the e-test will give you the value of the minimum inhibitory concentration, in which it is the lowest concentration that the drug inhibits the organism. So in CLSI guidelines, Again, vancomycin is very important. What we need to detect the MIC value because there is a rising cases of vancomycin intermediate staph aureus. So if we do this diffusion lang, we cannot differentiate if it is vancomycin intermediate or vancomycin resistant. So that is why we need to perform MIC result. And the 7 and 8 there class, this is an example of inducible clindamycin resistant test or your D test. Okay, it's very important so that we will know if whether the clindamycin is susceptible or not or can be used to treat your patient. Vancomycin, by the way, is the treatment of choice for MRSA. Next slide, please. Sige pa. Next slide. Sige. Go to your sige. Go to your, I think, flow chart. Go to your concept map. Okay, there. So they considered bacterial skin infection. Sige, go next slide, please. So what are the organisms? So the organisms they consider are staphylococcal species. So again, staphylococcal species are catalase positive, no? And most, only your Staphylococcus aureus is coagulase test positive. So epidermidis, saprophyticus, and lugdunensis are coagulase neg. Although lugdunensis may appear as positive on slide coagulase test, but when you perform confirmatory tests for tube coagulase, they are negative. Okay, so there, aureus is yellow colony and beta hemolytic. S. epidermidis are white colonies with a non-hemolytic. Saprophyticus, white colonies and non-hemolytic. How do you differentiate S. epidermidis from saprophyticus? Saprophyticus here is wrong spelling. S. epidermidis is novobiocin susceptible. Saprophyticus is novobiocin resistant. In some textbooks or in actual scenario class, saprophyticus may appear as yellow colonies. Okay, your saprophyticus again, these are associated with this is like a secondary causative agent, no, for UTI, and this is common among younger women who are active, sexually active. So a colony count of even though 10,000 colony forming unit that is considered as medically important. Unlike with your true UTI na dapat 100,000 CFU. Your S. epidermidis, these are associated with um, medically devices infection, no, mga prosthetic heart valves, mga joint infections, na mga may mga implants because your organism contains slime in which those slime will develop biofilm formation. Next slide, please. So there you have Staphylococcus aureus, and then review the different, next slide, review the different, next slide, review the different virulence factor. These are only not the virulence factor. There are a lot of virulence factor associated with staph. Okay? Dili lang kani, dili lang exfoliative, dili lang hemolysin, protein A, and coagulase. Again, for this case class, the primary virulence factor is your Panton Valentin leukocidin virulence factor. Okay? That is why your patient develops septic shock syndrome because your Panton Valentin is a dermonecrotic type of toxins. And once there is dermonecrosis, there is inflammatory responses, which will lead to hypotension and fever. Okay, your S. aureus also will release, may contain enterotoxins that is capable of food poisoning. That is why common sa mga protein-rich food as well as carbohydrate-rich foods is Staph aureus. Okay, I think that's the last. Ba? So you have their different types of and biochemical reactions. Sige, go. Okay. Okay. Again, Here, MRSA class is not a disease, ha? Or it's not an infection. Okay, this is an organism. Okay, thank you. Group 3, right? Group 3 for the presentation. Do you have questions before we proceed to the next presenter? If none, then let's proceed to group 5 for the next case. Thank you, group 3. Next group, case 2, prepare.
Yes, sir. For a moment po. Okay, hello, good morning. So we will be presenting the case study of Streptococcus pneumoniae. And we will start. Okay, so Mr. Jason Rules, 35-year-old working in a BPO. He had a 10-year history of smoking. 5 days prior to admission, he presented with a persistent cough and a fever. The cough was described as productive with greenish to brown colored mucopurulent associated with streak of blood. He sought consultation at their office clinic and was given antitussive meds and oral anti- antibiotics. One day, upon prior to admission, the patient cough and fever persisted. Patient also noted pain at the right chest that intensifies upon inspiration and difficulty breathing. The next morning, the patient was brought to the ER and subsequently admitted.
Physical examination include vital signs, blood pressure 90 over 60 mmHg, heart rate 120, respiratory rate 30 cpm, temperature 38.9 degrees Celsius, um, oxygen saturation 96%, head and neck unremarkable, cardio distinct heart sound and tachycardic, chest and lungs, no chest deformities, equal chest expansion, dullness at the end mid-lateral right lung field upon percussion, increased tactile firmness, rails RLF area. Past history revealed no previous hospitalization and surgery. He also denies he have diabetes, hypertension, and asthma. No maintenance medication taken, claimed to have bouts of seasonal allergic rhinitis, but no food allergy. He has complete childhood immunization, however, adult immunization is not dated.
His admission white blood cell count was 12,500 microliter with 750% neutrophils, and his hemoglobin was 9.0 grams per deciliters. Sputum gram stain at admission revealed 25 polymorph follicular cells and 25 squamous epithelial cells per low power field. The specimen was not processed further. Two blood cultures obtained at admission were positive for the organism seen in the figure 2.1, and the gram stain from the blood culture bottle is shown in figure 2.2. The patient was admitted to the hospital and treated with ceftriaxone intravenously, and upon effervescence, he was discharged on a regimen of oral azithromycin. And based on the organism's identification, and antimicrobial susceptibility results.
For the figure 2.1, direct ground-stained sputum, moderate gram-positive cocci in pairs, few gram-negative cocci in pairs, occasional gram-negative coccobacilli, and squamous epithelial cells. Figure 2.2 isolates from a positive blood culture bottle small grayish-white colonies and alpha hemolytic. The antibiotic this optokin showed susceptible. Now we will talk about the patient's general information. A case of JR of 35-year-old male. We will talk about the subjective and objective information of the patient. Chief complaint, persistent cough and fever. The cough produced as greenish to brown colored mucopurulent sputum with streaks of blood. The other symptoms, pain at the right chest intensifying upon inspiration and difficulty breathing. Now we'll talk about the history of the present illness. 5 days prior to admission, there's there's fever, cough with greenish to brown mucopurulent with streak of blood. 1 day prior to admission, positive of fever, positive of cough, and positive for the right chest pain with difficulty in breathing. Now we'll talk about the past medical history of the patient. There's no previous hospitalization and surgery, and there's a complete childhood immunization. The patient family history and the close for the patient family history, and for the patient social history, there's the patient social history is 10 years of smoking, and for the drug history is anti-tussive medication and oral antibiotics 5 days prior to admission. Now we'll talk about the comorbidities, which is none, and about the physical examination. The vital signs, blood pressure is 90 over 60 millimeter per mercury. The heart rate is 128 beats per meter. Respiratory rate is 30 CPM. Temperature is 38.9 degrees Celsius. Oxygen gases saturation is 96%. The head and neck, unremarkable. Cardio, distinct heart sounds and tachycardic. The chest and lungs, dullness of the mid-lateral right lung filled upon percussion. Increased ductile firmicutes, rails in the right lung field. Now we'll talk about the pertinent laboratory. The WBC count is 12,500 per microliter. Neutrophil is 750%, and hemoglobin is 9 grams per deciliter. The gram stain results gram-positive cocci. The sputum gram stain result is more than 25 polymorphonuclear cells and more than 25 squamous epithelial cells.
So down the direct gram staining, which is the culture there is the sputum. So the sputum should be get fresh. Then the gram stain principle is involves the ability of the bacterial cell wall to retain the crystal violet dye during solvent treatment. The gram-positive microorganisms have higher peptidoglycan. That is why they are purple in color. whereas gram-negative organisms have higher lipid content. That is why they are pink. So in this gram staining result, the moderate are gram-positive cocci in pairs. Next is the optokin test in blood agar plate. So the blood culture plate appears to be small, grayish to white colonies and alpha hemolytic. So in the optokin sensitivity test, it indicates susceptible or have a kanang zone inhibition of greater than 14 millimeter. So we will talk about the differentials. So the patient had a case of respiratory infection. So there are a lot bacteria that cause respiratory infection. These bacteria is in can cause in respiratory. So to consider are S. pneumoniae, S. viridans, S. aureus, M. catarrhalis, H. influenzae, K. pneumoniae, M. pneumoniae, M. tuberculosis. So as we see in the gram stain result, the gram the bacteria appears to be gram positive cocci pairs. So as you see here in the slide, please, S. pneumoniae, S. viridans, and S. aureus are gram positive, while the M. catarrhalis is gram-negative Diplococcus, while the H. influenzae are gram-negative bacilli or coccobacilli, and the Klebsiella pneumoniae are gram-negative and rod-shaped, while the Mycoplasma pneumoniae is not visible on the gram stain, and also the M. tuberculosis is weakly gram-positive and in rod-shape. And in sheep blood agar plate, the colonies appear to be small, grayish to white, and alpha hemolytic. So I consider S. pneumoniae and S. viridans because Staphylococcus appears to be beta hemolytic, and the S. pneumoniae and S. viridans are the bacteria that is alpha hemolytic in Streptococcus family or genus. And next is the optokin sensitive test. So the uh, greater than 14 indicate susceptible or sensitive. So the S. pneumoniae is sensitive to optokin test, while the S. viridans is resistant to optokin test. So we conclude that the organism or bacteria present in the respiratory infection is Streptococcus pneumoniae. So
So the patient experienced persistent cough, which is an indication of respiratory infection. Diseases to consider are lobar pneumonia and pulmonary tuberculosis. The physical examination shows that vital signs of 90 over 60 mmHg, heart rate 128, respiratory 30 cpm, temperature 38.9, um, oxygen saturation 96, head and neck unremarkable, cardio distinct heart sounds and tachycardic, chest and lungs, no chest deformities, equal chest expansions, dullness at the middle or lateral right lung field upon percussion, and increased tactile fermitus and Reals RLL. We consider the same diseases mentioned. The patient have a background of smoking for 10 years. Since the sputum culture shows wala. the the uh, the the sputum culture shows greenish to brown colored mucopurulent associated with streak of blood. As As mentioned, the organism is a gram-positive cocci and appears to be alpha hemolytic. Therefore, the disease is lobar pneumonia. Unlike TB, it cannot be stained by gram stain. Instead, it can be stained by an acid fast stain due to the presence of mycolic acid.
Diagnosis is lobar pneumonia. Now we'll talk about the bacteria, the characteristics and type, virulence factors, gram stain, and biochemical reactions.
Um, Taxonomy kingdom is bacteria, phylum Firmi, Firmicutes, class Bacilli, order Bacillales, order family Streptococcaceae, genus Streptococcus, and species Pneumoniae.
So, Streptococcus pneumoniae, like many other bacterial species, produce toxins that are harmful to its host. It has several surface proteins and physical structures which play a vital role in its pathogenesis. The polysaccharide capsule is probably the most important virulence factor of the pneumococcus. It has antiphagocytic capability by inhibiting C3b opsonization of the bacterial cells. The presence of the capsule prevents IC3b and the Fc of the immunoglobulins on the bacterial cell surface from interacting with the receptors on the surface of phagocytic cells, with the result that the organism remain extracellular. The capsule is crucial for colonization and prevents mechanical removal by mucus and can restrict autolysis and reduce exposure to antibiotics. And this bacteria, the peptidoglycan, waldecoic acid, and the lipoteichoic are the main components of the Streptococcus pneumoniae cell wall. The bacteria exhibit lipoteichoic, which activates complement and induces inflammatory cytokine production. Pneumolysin, Streptococcus makes a toxin, the pneumolysin. It is a 53 kDa protein that is cytolytic to eukaryotic cells that have cholesterol as a component of their cell membranes, particularly the respiratory epithelium. It promotes shedding and in turn enhances bacterial transmission. It also induces inflammation in hosts during colonization. Next is the autolysin. It causes lysis of pneumococci in the presence of surface active antigens or antimicrobials that inhibit cell wall synthesis. It releases toxic proteases. The choline binding protein A, or the pneumococcal surface protein, is one of the principal pneumococcal adhesins. It it is it is the most abundant proteins present in the pneumococcal cell wall. It aids in invasion of epithelial cells during nasopharynx colonization. The pili, this is the hair-like structures that are located on the cell surface of the S. pneumoniae. It contributes to the colonization of the upper respiratory tract and increase the formation of large amounts of TNF by the immune system during sepsis, raising the possibility of septic shock. This also helps avoid phagocytosis by the immune cells. And next is the immunoglobulin A1. So the IgA protein, it enhances the organism's ability to colonize the mucosa of the upper respiratory tract by cleaving IgA. Streptococcus pneumoniae uses hydrogen peroxide to reduce the growth of bacteria it may be competing with. So it causes damage to host cells and has bactericidal effects against competing bacteria. The pathogenicity islands carries genes encoding one or more virulence factors. So it encodes virulence factors and are normally absent from non-pathogenic strains of the same or closely related species. Then the biofilms are formed in response to to stress and harsh conditions to promote bacterial survival.
Characteristic gram-positive. It is gram-positive, lancet-shaped diplococci, encapsulated, facultative anaerobe, fastidious that is um, quoted in SBA with 5 to 10% um, carbon dioxide, alpha hemolytic, negative catalase, opticant sensitive, bile soluble. The blood in the blood agar it appears small, grayish in colonies. Colony colonies tend to dip down in the center and resemble a donut. If capsulated, colony may be mucoid and alpha hemolytic.
So the result in different biochemical reaction in blood agar plate, the Streptococcus pneumoniae appears to be small, gray, glistening, and colonies tend to dip down to the center, resemble a donut. In the hemolysis, the Streptococcus pneumoniae is alpha hemolytic, meaning it is incomplete or partial destruction of red blood cells in blood agar plate. In gram staining, it appears to be in purple, meaning they have thick peptidoglycan and is gram positive. And in catalase test, it is negative. And in oxidase test, it is also non-negative. It's not negative. In motility, it is non-mutile because the motility test is used to determine whether an organism is mutile or non-mutile. So mutile organism contain flagella, which helps them to travel beyond point of initiation, while the non-mutile doesn't. So next is the Kilong test. The Kilong test, it is positive. Yes. Next is the biosolubility. It is also soluble, meaning it has the ability to to lyse the sodium deoxylate. The optokin test, it is sensitive, while the Streptococcus viridans is resistant. The urease also negative, and the VAGS is negative.
Okay, so for the S pneumonia diseases, it would be lobar pneumonia, meningitis, otitis media, and sinusitis. And right now for the S pneumonia treatment, we have ceftriaxone and azithromycin. So Streptococcus pneumoniae causes the majority of cases of community-acquired bacterial pneumonia, and it is the primary etiologic agent of bacterial meningitis. Vaccines help prevent pneumococcal infections, and Streptococcus pneumoniae can be prevented by vaccination, proper nutrition, and management of environmental factors. It can also be treated with antibiotics, again, namely ceftriaxone and azithromycin. So to start with ceftriaxone, the mechanism of this antibiotic, it inhibits the cell wall synthesis. So the bacterium has a cell membrane and a cell wall that consists of peptidoglycan, which are the sugar molecules interlinked with peptide bonds. So the ceftriaxone Without the bonds, the cell wall will be unstable or it can even burst due to the osmotic pressure inside. So, in order for the cell wall to synthesize, there is an enzyme called transpeptidase in which it catalyzes the reaction that is necessary for the peptoglycan. And that mechanism is the target of the antibiotic ceftriaxone. So the ceftriaxone inhibit the activity of the transpeptidase so that so that no transpeptidase activity and there will be no cell wall synthesis. So the cell wall becomes unstable and the bacteria will be eliminated. And by the way, just to add on as well, antibiotics, by the way, can be divided into two groups on the basis on their effect on their microbial cells through two main mechanisms, which are either bactericidal or bacteriostatic. So the ceftriaxone will be bactericidal, in which the antibiotics kill the bacteria. So let's move on right now to the mechanism of azithromycin. So the azithromycin inhibits the protein synthesis. The bacterial mRNA needs to be translated into protein, in which the ribosomes are responsible for the machinery of translation. They synthesize the polypeptide chain, which will fold into protein. And the bacterial ribosome consists of two sapulents, namely the larger 50s and the small 30 sapulents. So the azithromycin interferes with the small 30s sapulents, and with that, the tRNA will no longer bind to the ribosome and protein synthesis will be inhibited. This does not directly kill the bacteria, but it will prevent the bacteria to grow due to the lack of protein. So, since azithromycin prevents the bacteria to grow due to the lack of protein, this is what we call bacteriostatic. And that will be all for the group 5 case presentation. Thank you.
Okay. Any questions from the class? You want to clarify sa group? Wala? Okay, I'll ask questions. You may show your faces, group 5. Okay. Is Streptococcus pneumoniae part of the normal flora? Is Streptococcus pneumoniae part of normal flora?
Yes, sir.
How does it?
Because there are commensal, sir. Meaning, sir, if ang katong meaning, sir, if immunocompromised ang koan, ang patient or ang tao, dira na mo koan ang Streptococcus pneumoniae, sir, murag mo infect sa person.
Okay. So in your case, what is the risk factor why the patient develops pneumonia?
Because of koan, sir, kanang 10 years of smoking.
So what's the effect of cigarette smoking?
Anak ni.
What's the effect of cigarette smoking to the transmission of pneumococcal? No? Or what's the effect of cigarette smoking that promotes pneumococcal transmission?
It is because if a person inhale the smoke coming from the different chemical from smoking, sir. So, 'di ba? If we inhale kanang there are na bronchus, alveoli, dayon wait sa. Ang okay, dire na lang dito na. So ang cilia, sir, dira ang cilia kay mao na siya mo-prevent sa kanang bacteria. Like iya murag silhigon gani niya. Tapos if ang Streptococcus pneumoniae mo stay siya, dira na ma-trigger or dira na magkuan nga ang cilia dili na gani ka kanang kasilhig sa katong bacteria na present sa iyahang lungs.
Okay. Kasilhig yun, no? Sige.
Mura na siya hair-like structure nga murag silhigon niya.
So
silhig.
yeah, it's correct. The cilia has parang expellatory activity, no, mucociliary
Yes, sir.
action na niya. So what happened is if there is cigarette smoking class, it promotes no pneumococcal transmission by bacterial shedding from the colonized host, which increase also the susceptibility to pneumococcal colonization. So ang buhaton niya, there is mucosal changes. So ang kato imong imong cilia, iyang mucociliary action maguba because of the effect of the smoke. So therefore, most of the organism instead nga ma-out sila, di ba? As you said, na masilhig sila outside, murag pugaw lang. Okay?
Stay siya, sir.
If Mustacia, and then some of it can go to the lower respiratory tract, which is supposed to be sterile. Diba? Kay sterile man yun atong lower respiratory tract. Okay? And remember, the organism also contains IgA1 protease, which will inhibit the action of IgE nga supposed to be instead kung maguba ang tong silya, dapat atay mga immunoglobulin nga mga barriers. Di ba si IgA kay present man na siya sa mga mucous membrane na supposed to be naapata siya. But si organism contains this virulence factor that will try to destroy the IgA antibodies. That is why it can penetrate more. Okay, going to the lower respiratory tract, and it will cause eventually infection. Kaya if na naka sa lower respiratory tract, sterile naman siyang site. So, okay, very good. Next question. Go back to your tatong concept map.
Yes, sir.
Ana, okay. I assume that you wrote all of the organisms to consider based on the gram stain results, right? So the gram stain result is gram-positive cocci, gram-negative cocci, and gram-negative cocobacilli.
Yes, sir.
Okay?
Pero mas moderate man ang gram-positive cocci in pairs po.
So based on the result, no, nadiri gibutang ninyo and as after this 1, 2, 3, 4, 5, 6, on the 6, 1, 2, 3, 4, 5, 6. You have their alpha hemolytic, but why do you include Staph aureus? Strep pneumoniae, Strep viridans, Staph aureus.
Staph aureus man good, sir, kay gram-positive.
And then, alpha hemolytic ba yan na inyong gibutang dira? Is Staph aureus alpha hemolytic?
Diri, sir, kanang sa gram stain, di ba? After gram stain, gram positive. So ang ako ang gi-indicate kay ang three bacteria, Streptococcus pneumoniae and Streptococcus viridans o Staphylococcus aureus. So in the co-answer, strip blood agar plate, ang gi-indicate man ngadto ay ang the result kay alpha hemolytic. So mao na wala na nako gi bold ang Staphylococcus aureus, murag ako na siya gi-omit, sir. Mao na ang duha
Okay.
na lang. Oh, yes, sir.
So dapat next time do not do this kay maglibog ang reader.
Okay.
So dapat ang nakabilin na lang dira is your Strep pneumoniae and Strep viridans. Then going to optokin sensitivity, dapat ang mabilin na lang dira is your Strep pneumoniae. Wala na ning last na organism.
Okay, sir. We'll do that next
So
time, sir.
remember that because you will do more of this when you go to fourth year for internship and for if you want to proceed to medicine because you will do more of case prep. Okay. Based on the case, di ba, it mentioned about the result of sputum, quantitative result of sputum, the response cells and epithelial cells, right?
Yes, sir.
Okay. Is the sputum sample adequate or can you consider this as an ideal sputum sample? Oy. Can you consider this as an ideal sputum sample?
Yes, sir. Ideal siya, sir.
Why?
Since we talk about the respiratory infection, sir. So there are a lot of kanang like makakuha ta og sample sa anang CSF. But this sir, ideal gihapon siya, sir, kay gi-excrete man siya from lungs, sir, or respiratory.
Okay. I am asking if the sputum quality is correct or not.
Yes,
You
sir.
consider this as true sputum sample or Not.
It's ideal, sir, because the number of epithelial polymorphonuclear cells there is greater than 25.
How about for your epithelial cells?
Uh,
Actually, class, the correct answer is not. That is why if you read the case, di ba, wala siya ng-culture sa sputum. The growth is
yes, sir.
from the blood culture. Am I
Blood
right?
culture.
Because the sputum quality from the result, no, the quantitative result of your epithelial cells and your pus cells, it signifies that it's not a real sputum sample. It's only saliva. Okay? Remember Bartlett's criteria? Di ba? Dapat ang true sputum sample should be at least less than 10 squamous epithelial cells with more than 25 pus cells. Okay? So, dili siya ideal. Munang wala siya gi-proceed to culture. Okay? But, luckily, the patient still, luckily, yun no, the doctor still get the result no via blood culture. So meaning the patient class is not only limited to lobar pneumonia. The actual diagnosis of the patient is community acquired pneumonia with bacteremia. Kaya naman siya organism sa iyang blood,
Mm,
'di ba? If community acquired pneumonia lang siya, meaning wala kay makuha sa iyang blood, but the growth of the organism that you identified, that you do your susceptibility with optokin is from the blood culture. Tama? So
yes,
meaning,
sir.
may pneumonia si patient, may bacteremia din si patient, in which ang causative agent is your Streptococcus pneumoniae. Okay? So the rest, no, from the sputum sample, or from the gram stain class, no, gram stain is only a presumptive diagnosis. Parang it will give you an idea, but it will not really give you a conclusive diagnosis kung unsa ni siya. Because your sputum, respiratory samples like sputum class will have the several growth if imo na siyang i-culture on a culture medium. Kaya remember, a lot of normal flora is present sa atong mouth. Okay? So, when you do culture, munang in the laboratory, only skilled na mga kanang medtech assigned sa laboratories ang maka-identify jud og true pathogenic pag sputum sample. Mo na pinakalisod. If ever ma-assign ka sa micro, no, mo na pinakalisod nga sample nga imong i-test, imong kuan kay tanan makita nimo motubo man. So you need to identify which among the colonies is you think pathogenic to the patient. Okay? Next question. Why do you think the organism is alpha hemolytic? Why do you think the organism is alpha hemolytic?
It's because it has a capsule star and the colony is mucoid.
Ha? Pagcapsulated og mucoid kay alpha hemolytic, dili manggod. Unsa may makakos nganong may hemolysis be sa blood agar plate?
Ay
It caused by
partial,
the
ano siya, sir?
answer. It caused by the oxidation of the oxyhemoglobin produced by the hydrogen peroxide.
O unsa man na siya? Because of what? Which virulence factor?
Hemolysin, sir.
Hemolysin, sir.
Hemolysin, particularly your kinsa man asa man ato sa inyong na-mention nga virulence factor. Nganong alpha hemolytic siya. This because of the pneumolysine. It's the pneumolysine that is why it is alpha hemolytic na alpha hemolysis. Yung appearance sa blood agar plate. Okay? And again, class ha, remember, there is no koksay na trismotil. Wala gyud na sila yung flagella ang mga koksay. Mostly bacilli gyud na ang naay mga flagella or mga spirals. Okay. Um, I'll ask questions from the class. Aguirre? Aguirre is around? Oy, Aguirre. Aguirre, Erica? Wala?
Yes, sir.
Are you around?
Yes, sir.
Okay. Your classmate mentioned about optokintes. What is the other name for optokintes?
Taxopi, sir.
What's the chemical name?
Basitrasin po, sir.
Huh? Bacitracin?
Balik sa question, sir.
What's the chemical name of optokintes? Optokintes?
Ethylene hydroprene, sir.
Oh.
Ethylene hydroxyprene, sir.
Wala? Wala sumpay?
Hydrochloride, sir.
What's the positive result? What's the positive result? What's the positive result for optokintes?
Greater than 14 millimeters, sir.
Which organisms give you susceptible?
Streptococci pneumoniae, sir.
Ha?
Streptococci pneumoniae.
Okay.
Okay, oh. Dili ko. Kapalit man siguro na.
Dili, coffee na. Coffee na.
Coffee na. Dili na. Thank you. Sampo. Doon yan na lang tayo mag-coffee ko ito.
Next, Salamida. Salamida, are you around?
Yes.
Okay. Question. What the major virulence factor of the organism? Of the causative agent?
Polysaccharide capsule.
What's the function or what's the action?
Major virulent,
What's the action of the polysaccharide capsule?
prevent the WBC,
Huh? Prevent the WBC from what?
it
Prevent
protect
WBC?
it protect the bacteria from phagocytosis.
Okay. So, what is the expected appearance of the colony if ever it contains polysaccharide capsule?
Mucoid,
Huh?
mucoid po.
Okay. Um, Mirales, are you around? Francisco?
Yes, sir. Present, sir.
Okay, they mentioned about treatment of ceftriaxone and azithromycin. What's the action of ceftriaxone and azithromycin? If you listen to the report kanina and if you read their paper, what's the action of ceftriaxone and azithromycin?
Ano, ano, sir,
The what?
inhibits the cell wall synthesis, sir, from synthesis. Inhibits
Which
the cell wall synthesis, sir. The
which one?
bacterium has a cell membrane and a cell wall that consists peptidoglycan, sir.
How about azithromycin?
Inhibits the inhibition of protein synthesis, sir.
Which protein or which ribosome specifically? It binds to what? It binds to which ribosomes? Ah,
mRNA, sir.
huh? mRNA? Is mRNA correct, reporter? Reporters. Azithromycin binds to which protein? Which ribosome? Ganina gani reporter?
Kana 50 and katong katong two supplements, sir, which is the 50 the larger and the small which is the 30 supplement.
Sa duha day siya mo bind group. Sa 30 or
No, sir.
asa man siya mo bind specifically? Sa 30 or sa 50?
Sa 30,
Sa
sir.
30, sir.
Okay, sa 30. Okay, reporters, I have last question. Have you read about vaccination on Streptococcus pneumoniae?
Yes, sir. I read some, sir, but
Okay,
kanang nag-focus lang ko.
can you
I'm sorry, sir.
share to them how can we prevent pneumococcal infection through vaccination? What are the most common vaccines available? Reporters?
Wait.
Um, based sir sa research sir, the most there are two kinds of pneumococcal vaccines which is available in United States. Pneumococcal conjugate vaccines, which is PCV13, PCV15, and PCV20, and pneumococcal polysaccharide vaccine, which is the PPSV23.
Okay. Which among the two vaccines protects you for 5 years? Kinsa man ato nila?
The con sir, PPSV23 sir.
Okay, good. Okay, let's recap the case, no? So the case is a BPO patient who has a 10-year long history. Can you go back to the 10-year long history? So he complained, no, um, persist. He went to the hospital because of the persistent cough with fever and oh yeah, persistent cough and fever with a right chest pain. Next slide, please. Sige pa. So during his admission, doctor requested sputum culture, sputum gram stain, acid fast supposed to be if mag sputum gram stain class na yun na kuyog ang acid fast staining would no and blood culture because the patient experienced fever. Okay, so remember, ideally the sputum should be less than 10 squamous epithelial cell. Squamous epithelial cells like this kaning nasa center ang tanang pinakadako, no, and more than 25 polymorphonuclear cells. It meaning it indicates active infection if daghan ka og polymorphonuclear cells like your neutrophils. So in the gram stain, they noted gram positive cocci in pairs, gram negative cocci in pairs, and gram negative coccobacilli. Okay, so most likely it will not give you class really a good conclusion which organism because this is mixed, diba? So when you do culture sputum on a culture media, daghan din na motubo. Kay tungod sa mix man na sila, kay kuyog man na sila sa imuhang mga normal flora. So here, based on the microscopy, so the sputum was not proceed no to culture, but instead only the blood culture. So the blood culture after 24 hours, it reveals alpha hemolytic, small grayish white alpha hemolytic. Proceed to the next slide. Alpha hemolytic na colonies. So before nimo siya butangan og disc no optokin disc class, you need to check muna the gram stain. So from the bottle, from the culture bottle nga positive, imo na siyang i-gram stain. So if you will see lanceolate shape or in pairs no na cocci, so you tawag nito, it will give you an idea na possible streptococcus siya. So, you can place in some laboratories, dili lang ang optokin disc, pwede po na nila butangan sa opposite side o bacitracin disc. Okay? Para at least duha. Diba? In case kung dili siya alpha hemolytic, at least if beta hemolytic, nagyapon kay result, dili ma-delayed ang result ni patient. Kay per culture class, obviously, wala na yung stat na result. Okay? It will really kung nagani yung doktor nga mo request for stat for culture, sunga na siya. Okay, wala dyan ay stat ang culture result because dili man na pwede nimo patubuon ang organism 2 hours after. Okay? So here, the organism is susceptible to optokin. Again, your optokin is also called as your taxop, and then the chemical name is ethyl hydrochlorine hydrochloride. Okay, so this is susceptible. So susceptible for or positive results for optokin test that's more than 14 mm. Diba? Next slide, please. So most of the antibiotics class for streptococcus, di ba? For alpha hemolytic, by the way, alpha hemolytic strep, you will only ident- there is only two medically important na organism. You have the strep viridans and your streptococcus pneumoniae. So in order to differentiate the two, you need to perform optokin testing. So resistant si strep viridans, sensitive naman si strep pneumoniae. Remember that always. Okay? So most of the antibiotics, susceptible pa naman yung pneumococcus. Pero there is increasing reports or studies na resistant sila to penicillin. That is why penicillin are not usually given to patients. So instead, they will give another beta-lactam drugs or erythromycin in some, no, they can also give erythromycin for some patients. Lalo na, you will not give penicillin to the patient that are allergic. So you may give erythromycin or vancomycin as treatment of choice. So there are also other books, ceftriaxone, azithromycin can be used for treatment of lobar pneumonia. Okay, so again, the final diagnosis for this case is community-acquired pneumonia with bacteremia. Okay? So when you become doctors, ang community-acquired pneumonia class, dili lang ka mo settle sa community-acquired pneumonia nga word. You need to grade that one. If it's high risk, moderate risk, or low risk. So in that case, this is moderate risk na community-acquired pneumonia. So dili lang taan because you're not medical students. Okay? Questions, clarifications? Wala? So let's proceed to the last case. Thank you, Group 5. Tama, Group 5.
Yes, sir. Thank you, sir.
Thank you, sir.
Group 7, prepare. Try share your presentation.
Sir, hello, sir. Good morning. We are from Group 7, and we will be presenting for our case study for this morning. So the case is patient Joy, a 35-year-old woman, presents to the emergency department with right flank pain. She reports that she had a few days of urinary urgency, frequency, and burning, which she tried to treat herself by drinking cranberry juice. Earlier today, she started having severe cockingly pain in her whole right side. She, had, she has had a fever, and when she urinated this morning, she noticed that it appeared to have blood. She had a few urinary tract infections in the past, but nothing like this. She is on, she is on no medications regularly and has no regular significant medical history. On the examination, she has a temperature of 37.5 degrees Celsius. Her other vital signs are normal, and she appeared to be in pain. Notable in examination is some tenderness in the right flank but no masses, rebound tenderness or guarding on palpitation of her abdomen. She has costovertebral angle tenderness on the right side but not on the left. Her peripheral WBC count is elevated, and urinalysis show the presence of leukocyte esterase, blood, and high pH. An abdominal CT scan reveals an obstructing stone in the right ureter causing hydronephrosis of the right kidney. So for the urine culture result, it is seen to have swarming colonies with burnt chocolate odor in blood agar plate. While for the McConkey agar or the Mac or urine culture results colorless colonies, which indicates lactose or non-lactose fermenters, and the colony count is more than 100,000 colony forming unit per ml. So for the biochemical tests, the patient is positive in indole, positive in methyl red, negative in Vaux pros or on BP is negative and negative also with citrate. So for TSI, it is alkaline acid and positive with hydrogen sulfide. And for SIM, it is positive and positive also with urines. So for the patient's data, so the patient is a 35 years old female with a as I mentioned earlier, the patient is a 35 years old female with a chief complaint of right flank pain and experience other symptoms such as fever, urinary urgency, frequency, and burning sensation. And also, urine appeared to have blood.
In the history of the present illness, in the unit, the patient present of urinary urgency, frequency, and burning. In the early today, the patient experienced severe stopping of the whole right side, fever, urine with appearance of blood. And the past medical history, the patient was associated with few urinary tract infections.
Is the family history. Family history is undisclosed, so meaning the patient did not include her family history. Social and drug history is no medication.
The comorbidities is none. For the fever examination, it shows that the patient has a temperature of 37.8 degrees Celsius. Her other vital signs was normal. It also appears that the patient is in pain and has costovertebral angle tenderness on the right side but not the left. For the pertinent laboratory, patient's peripheral white blood cells count was elevated, and on her urinalysis showed prostate state blood and a high. On the patient's abdominal CT reveals an obstructing stone in the ureter causing hydronephrosis of the right kidney. Hydronephrosis is swelling of one or both kidneys that happens when urine can't drain from the kidney and builds up in the kidney as a result. For the result of urine culture, colony count has a total of greater than 100 colonies per milliliter, and swarming colonies with a burnt chocolate odor on blood agar plate and non-lactose fermenters in McConkey. For the biochemical test in chocolate agar iron, it shows over acid with the presence of hydrogen sulfide. For the IMT, it is positive both in methyl red while negative in both red and and positive for the motility, and lastly negative for urea. I mean positive for the urea.
For the differential diagnosis, we have three possible methods: UTI, nephrolysis, and pyelonephritis. This as a round pair, we can observe this as a urinary symptom, and then we can consider this as UTI or the presence of renal stones and pyelonephritis. Through further physical examination, it is found out that there is tenderness on the right flank and costovertebral angle tenderness on the right side. Costovertebral angle on the right side meaning the right rib. And through urinalysis test, there are two results, hematuria and pyuria. For hematuria, we consider nephrolithiasis, and then for pyuria, we consider UTI or pyelonephritis. So the final diagnosis would be UTI with nephrolithiasis, which means there is a presence of renal stones. For the organism identification and differentiation, there are three organisms that can possibly cause UTI with nephrolithiasis. These are Proteus mirabilis, Proteus vulgaris, and E. coli. So on the previous slide, we saw that on the agar culture blood agar plate, there is a presence of a swarming colony, and then for the McConkey agar, the colonies were colorless, indicating that they are a non-lactose fermenter. So from this information, we can crash out E. coli from the list, since E. coli is rarely a swarming colony and is a common lactose fermenter. So we are left with P. vulgaris and P. mirabilis, which are both common swarming colonies and they are never lactose fermenters. For the biochemical tests, for the INVIC test, which stands for Indol, Mithoret, VP, and citrate utilization test, for Indol, our organism tests positive, which um, infers that our organism Mithoret test. This test if the organism can produce acid end products for fermentation. It's positive. And then for VP test, it tests if the organism can reduce acid urine is negative. And for citrate utilization, this test is for testing if the organism can use the enzyme citrate permease to reduce hydrolyze citrate pyruvate for um for energy production. So this is negative for organisms that use or utilize as for energy production. And then for TSI, it's unrelated and it is positive. Meaning it is a non-lactose fermenter and then is a glucose fermenter for acid. And then for H2S positive means the organism can reduce acid into sulfide. And then for motility test, um, there would be spreading out of the organism, meaning it can move and it is motile. For urease test, these tests if the organism can produce the urease enzyme to hydrolyze urease to produce hydrolyze urea and then produce ammonia and CO2. So this comes out positive. So with our biochemical tests, um, we can use this to identify our
Excuse
organism.
me, where is your presentation now?
Since permeabilis comes out negative for indole, then we can crash out
Hello.
this organism. So our organism would
Wait.
would no other than be P. vulgaris, which is positive for indole,
Excuse me, wait
positive
lang.
for methyl red,
Soy, kadali.
negative for VP test, and negative for citrate, and is a H2S positive.
Excuse me. Where is your presentation now? You keep on talking without presenting? Tama ko? Or have you... Can you present again your PowerPoint presentation?
Sure, sure, problem.
Before you proceed, present again your PowerPoint presentation. How will your classmates know what you're
Okay, sir.
talking about? Okay, proceed.
Proceed. Proceed. So our organism would be vulgaris since test positive, and then methyl red positive, and then VP negative, citrate negative, and test positive. So we can see a image microscope the Proteus vulgaris. It's a gram-negative bacilli. Since for the taxonomy of Proteus vulgaris, it is under phylum Proteobacteria, class Gamma Proteobacteria, order Enterobacterialis, and then family Enterobacteriaceae, genus, and then species is characteristics of bacteria and structure arrangement in pairs or in sometimes in clusters. For flagella, a per meaning um, flagella are in other correct. They are actively motile, non-performing growth. That's why they are um, motility test positive. And then for capsules or spores, they have none. Then gram stain, they are gram negative since they are colored pink or red in stain. And then they are facultative anaerobes, meaning they can survive with or without the presence of oxygen. And they are naturally resistant to antibiotics. And then they are the strains of people are more resistant to general antibiotics. And for virulence factors, there are many virulence factors associated with P. vulgaris. Fimbriae for the adherence of bacteria to the epithelial tissue, flagella for movement, O and capsular polysaccharides. For filming facilitation, this can be seen on the blood agar plate. Biofilm for protection of bacteria against antibiotics and immune mechanisms. Urease, elevation of urine, pH, and then protease for elimination of phagocytosis and invasiveness for penetration and internalization of bacteria into cells. There are other types of Proteus vulgaris. They are multi-drug resistant and plasmid-mediated beta-lactamase acquired resistant. And then for the characteristics in culture media, we have seen on the images on the blood agar plate, they are irregular in shape since due to swarming. And then for the McConkey agar, they're circular, colorless colonies because they are non-lactose fermenters. And then for the biochemical reactions, gram stain negative, indole test positive since it has the enzyme tryptophanase, methyl red positive since it can produce acid end products from glucose fermentation, VP test negative since it cannot turn acid into acetylene and 2,3-butanediol, citrate negative since it cannot utilize citrate for energy production, then TSI since um, alkaline acid, and then H2S positive since it is a non-lactose fermenter, glucose fermenter, and sulfite, and it can reduce sulfite into sulfides. And then for SIM test, it stands for sulfite, indole, and motility test. So it tests positive since it is motil, and then indole positive, and then sulfite can reduce sulfite into sulfide. And then for SIM, it is also positive since it has enzyme to reduce or utilize urea to ammonia. And are the diseases associated with Proteus vulgaris? UTIs, wound infection, pyelonephritis, or irritable red blood cells, urine, pityriasis, burn infections, skin infections, respiratory tract infections, and chronic infections.
So first, pith. Most or there are most of the Proteus vulgaris strains are resistant to that would be Cephalus, one or Cephalozoa and Cephal. Next is tetratetrans. The third so for tetraclines, for the nitrofurantoin is cysteine. So for the choice of treatment for Proteus vulgaris, we have ceftazidime. So ceftazidime inhibits cell wall by binding with um, P, PBD or penicillin binding proteins. So this results to the loss of cell integrity and bacterial cell death. So for the second one would be aminoglycosides. So aminoglycosides um, binds to 50S ribosome to the aminonucleotides of 50 of 16S ribosomal RNA, leading to misreading of genetic code and inhibit translocation. Next would be carba carbapamine, which is penetrate cell wall of bacteria, binding with the penicillin binding proteins that inactivates enzyme that would ultimately kill the bacterial cell. And lastly, the third generation cephalosporins, which also inhibits cell bacterial. That's for our examinations.
Okay. Do you have questions? I don't know if My internet is unstable or your area is unstable. Okay, do you have questions from the class? Wala. What's your final diagnosis, reporters?
UTI and nephrolithiasis, sir.
And
Nephrolithiasis.
nephrolithiasis.
Yes.
Which area?
Right side, sir.
Okay, it should be noted also.
Yes,
So
sir.
the correct diagnosis should be complicated UTI because 'di ba, if you read the case, she always have UTI, mga recurrent UTI. So complicated UTI with right, you know, nephrolithiasis. Okay, question. What causes the swarming colonies on your blood agar plate?
One, sir. O and capsular polysaccharide.
Huh?
Flagella and O.
Flagella. Describe the flagella of your Proteus vulgaris or Proteus in general?
Invertebratus flagella, sir, meaning daghan siya kanang flagella then arranged in many in the
In
organism.
arrange in ano? They're arranged all around the body of your bacterium, right?
Oh, that's what I
So um your organism also is capable of forming kidney stones.
yes.
Can you explain how?
It is because the Proteus vulgaris is urease positive. Uh, urease can hydrolyze urea, then produce ammonia and CO2, which makes the environment of the kidney more alkaline, then that can result to the formation of kidney stones.
Mura? Pag mag-alkaline, mauna dayon. After, di ba, hydrolyze siya to ammonia and carbon dioxide, your hydrogen will bind to the ammonia that will form into ammonium together with other compounds like your magnesium, your phosphates, it will precipitate that will form kidney stones. Tama?
Yes.
And if there is rapid reproduction of the organisms, it will form biofilm, and that kidney stones will accumulate, forming calculi. So the calculi is described to be or named as, what's the name of the calculi?
Renal calculi.
Ha? Gawas. Na, what the name? Or the description of the calculi? Staghorn calculi. By the way, what's the name of the crystals form?
Strobite, sir.
What's the other name for struvite?
One, sir. Strobite, sir, is also known as magnesium ammonium phosphate.
Okay, very good. Do not forget that you have already your AUBF. Um, sige. Other question. The organism is non-lactose fermenter, right?
Yes.
sir.
So what's the expected result for TSI?
TSI. Alkaline siya, sir, since they cannot ferment lactose.
Okay. I'll ask question from the classmates. I'll have Absin. Is Absin around? Shaniki? Okay. Aside from the uh, TSI result, okay, which enzyme is rapidly produced by the organisms that will give you a red slant result sa imuhang LIA? Again, question, Shanike, which enzyme is produced by the organism which will result to a red slant in your LIA tube? What is detected on the LIA DIB? Huh? What is detected on your LIA? The slant portion detects what? This is last week pa nga discussion. Nalimtan dayon sa inyong laboratory? That is lysine. Ano pa? Unsa man to nasa slant di ay? Unsa man to yung gidit? Unsa man to yung purpose ato sa slant? That is for
Glycine deamination.
deamination or deaminase. Okay. What's the positive result?
Red, sir.
Red slant.
Red. Yeah. Ay,
How about the butt portion? What does it detect?
ang bat niya, sir, guys. Unsa di ang question, sir?
What's the test detected on the butt portion, or what's the enzyme detection detected on the butt portion?
Decarb, decar, decar,
Because what?
silase, sir. Sir?
What's the positive result?
Unsa? Sir?
What's the positive result?
Of purple, sir.
What's the negative result?
Red.
Red.
Ay, yellow, sir.
Why yellow?
Ay, negative one siya. May negative siya, sir.
Okay, negative siya?
And kuan man siya kanang yellow siya kay unsa to? Yellow siya ang iyang ferment kay glucose raman.
Okay. Okay, another question. Intriso Maria Jona, are you around?
Yes, sir. Yes, sir.
If ever the organism, no, the organism, diba, shows colorless colony on a McConkey agar, what is the expected result on a TSI?
TSI. Answer. Alkaline, sir.
What's the expected result? Tell me the whole result of the TSI.
Um, K over A, positive for H2S or hydrogen sulfide.
Okay. What's the pH indicator of TSI?
Phenol, phenol red, sir.
How about the H2S indicator?
Ferrous ammonium sulfate.
Good. Next. Solonia, are you around?
Yes, sir.
Okay. Wait, I look for a question. What is the expected colony count if it's through UTI? Miss Solonia.
Yung colony count niya is 100,000 po.
If it's less than 100,000, what will you do if ever you'll receive um or you'll see two colonies on a blood agar plate with a colony count of 100,000? Will you proceed it for identification or not?
Not po, sir.
Why?
Daw, if ever na, ang sayang presumptive, no.
Okay, not the presumptive.
Okay daw. Apo, kay kung ang presumptive, okay. Kay kung no siya.
You will see two colonies, meaning different colonies on a blood agar plate. But the colony count, if you count the two colonies, di man ka pwede mag-count og one colony, two. Yung counting anak class is the whole colonies present on the plate. You said that you will not proceed it. Why?
If the presumptive, if 100, presumptive na if 100,000 colony count.
Oh, ganun di ba sabi mo kanina dili nimo i-proceed? Why? What's the reason?
Change na nag-change na lang po kasi kung 100,000 lang yung presumptive count.
No, di ba? You will see two colonies on the blood agar plate. And then the colony count is 100,000. Di ba sabi mo kanina, i-proceed mo for identification or not? Will you proceed?
Proceed po, sir.
Proceed?
Proceed po, sir. Opo.
You will identify the two colonies? This is a previous topic for specimen collection ba ya? Proceed or not?
Hindi po sir.
O nga naman.
Kay, oh,
Dai? Any idea? Dili nimo siya i-proceed class because it can be no mixed culture, meaning basin contaminated imuhang specimen. So if ingon ana gani more than 100,000 imong colony count at you'll see 2 to 3 or 2 to or more colonies present, lain sila now. So you do repeat collection. Okay, you request another specimen from the patient or you call the nurse station and then do repeat collection for that. Okay, this is a basic question class from specimen collection. So I assume that you already know this. Okay, let's recap the whole thing. Go back to the first slide. So the patient is having recurrent UTI, tama? Okay. The patient have few urinary tract infections in the past and he had no medication, has no significant medical history. Sige. Next slide, please. So on an examination, she revealed temperature of 37.5. Her major chief complaint is the right flank pain, but upon abdominal checking, no rebound tenderness and or guarding on palpitation. And she has cortovertebral angle tenderness on the right side, but not on the left. Okay, so her peripheral smear revealed white blood cell count increase, meaning there is an active infection, and urinalysis shows presence of leukocyte esterase. So therefore, there is possible that the patient may have a UTI, blood, maybe the patient, there is a destruction maybe of the kidney in a high pH, so the urine appears to be alkaline. So you'll expect there is a destruction sa kidney because there is blood, and sometimes you will see proteins also increase. So that's why the blood of your urinalysis will prove you that there is destruction due to the abdominal CT scan. The abdominal CT scans reveal obstructing stone and the right ureter. So let's go to the organism. Let's go to your concept map. Sige. So the final diagnosis for this infection is recurrent UTI or complicated UTI with right nephrolithiasis. So the organisms that could be considered are Proteus mirabilis, Proteus vulgaris, and E. coli. So on a blood agar plate is swarming colony. So the swarming is because of the flagella as well as the O and the capsule of the present sa imuhang organism. So the McConkey appears to be colorless, meaning the organism does not ferment lactose at all. By the way, the organism also has a distinct characteristic odor, which is a burnt chocolate odor due to the hydrogen sulfide formation. So upon investigation, so you have there Proteus mirabilis and Proteus vulgaris. So because of its non-lactose fermenter, you rule out E. coli. So wala na siya appeal. So eto na lang dalawa. So in order to differentiate Proteus vulgaris from Proteus mirabilis, you check the indole reaction. So indole positive, it's vulgaris. Indole negative, it's mirabilis. Okay. Next slide. So you have there the gram stain. Sige pa, next slide. Wala na? Okay, next slide. Okay, next slide. Next slide. Okay, so these are the virulence factor of your fruit juice. So how does your fruit juice cause infection? Remember, your fruit juice class is very motile, no? So their motility will help them ascend to the ureter, going to the kidney, okay, because of the flagella. Once they reach to the kidney, they try to penetrate and adhere to the ureteral tissue using their membrane, their somatic pili. So they will attach there. The organism also contains proteases, primarily your IgA proteases, no? That will destroy the IgA antibodies present in the mucous membrane. So it can unang mo makapenetrate gid siya. And your organism also has urease enzyme. This urease enzyme will help the organism to live in the acidic environment. So iyang buhaton, iyang alkalinize ang kanang environment. So once it release urease, di ba, the urease will convert urea to ammonia and carbon dioxide. Si ammonia will get hydrogen present in the body. So maging mo siyang ammonium. Ammonium binds together with other compounds like your magnesium, calcium, and phosphates that will precipitate since alkaline naman ang urine. So these chemical components will form into crystals. So ang tawag, or stone, ang tawag niya, di ba, is the struvite or your ammonium magnesium phosphate crystals. And then group of stones, di ba, rapid reproductions of the organism. So mag-form siya into biofilm, and then mudako siya, mudako ang stone, it will form into renal calculi, or your, in some textbook, they're described to be staghorn calculi. So which will results to destroying sa kidney mo nang nakay blood makita sa urine. Okay. Next slide. So you have also, yeah, Purchus vulgaris is known to be multi-drug resistance. A lot of Purchus strains, a lot of Purchus species are known to be multi-drug resistance. So that's why it's important to note the susceptibility pattern for Purchus organism. So treatment of choice, you go to the treatment of choice. So you can give ampicillin, cephalosporins, tetracycline, nitrofurantoin, and colistin. Nitrofurantoin is only given to patients with UTI. Okay? Urine rani ang nitrofurantoin nga antibiotics. Okay. Any questions? Clarifications? Wala na? Okay. Thank you, Group 7, for the presentation. Thank you, everyone, for attending this case prep. I hope you learned something from the case presentations. No? I hope you're also writing down the notes or the words that I uttered, because it might come out during your P2 exams. Diba? Wala pa ba kayong P2 exams? So, if you have questions, feel free to message me directly via our group chat or message me individual. Okay. So, wala na questions? You can now go and have a great lunch, everyone. Stay safe and goodbye.
Thank you,
Thank you,
sir.
sir.
Thank you, sir.
Thank you,
Thank you,
sir.
sir.
Bye, sir.
Dili mo.